Good afternoon. Mr. Byrne, I think you're next.
My lady, I wasn't expecting to be, but I can.
Oh, sorry. Why weren't you? Anyway, why don't you have a go?
Thank you, my lady.
Sorry for the confusion.
Good afternoon, my lady. Brynhawn Da. I appear on behalf of the Welsh Government. The Welsh Government has listened closely to the oral evidence and submissions you have heard this month. The Welsh Government's written closing statement will address in detail the important issues that Module 5 has raised for Wales. Today, I will focus on some of the principal points that have emerged from the evidence, lesson learned and recommendations. One of the questions asked of Welsh Government witnesses was why there were experiences of local PPE shortages, even if, as the evidence showed, stocks never ran out at a national level in Wales. The inquiry heard from Alan Brace, who on the 23rd of March 2020 led the Welsh Government's work in sourcing and distributing PPE in Wales. Mr. Brace told the inquiry that he was aware that there were difficulties in the very early stages of the pandemic in relation to the distribution of the pandemic stockpile. He identified the problem that he saw, that the emergency planning for PPE was based on a push system, whereby standard packs of stocks were pushed out to the NHS. This was different from how the NHS in Wales usually operated, which was a pull system by which local health boards requested stocks as needed. One of the lessons he drew from the pandemic was that it was unhelpful for the emergency PPE supply process to work differently to the usual system of supply. Mr. Brace told the inquiry that on taking up his role, he was in daily contact with the PPE leads of local health boards. And throughout those meetings, they assured him that the local health boards were receiving sufficient stocks of PPE. However, as was noted in our written opening statement at the outset of this module, the Welsh Government accepts the evidence heard during Module 3 that delivering PPE stock to the local health boards did not necessarily mean that it always reached the right hospital or the right ward. An important lesson that therefore arises is the need for local health boards and NHS trusts to ensure they have robust local stock management processes in place which can be appropriately expanded during a time of heightened demand, to ensure that supplies received from the NHS Wales Shared Services Partnership can be efficiently delivered to the right hospital and to the right ward. In relation to local PPE shortages within the care sector, Mr. Brace recalled an instance of a call in late April 2020 informing him that a care home had run out of PPE and that there was none available within the local authority to replenish their stocks. And Mr. Brace told the inquiry that he contacted the NHS Wales Shared Services Partnership. A van was duly sent to the relevant joint equipment store, and shortly thereafter it was confirmed that the store was in fact full of stock and that there was simply a communication or distribution issue between the local authority, the joint equipment store and the care home. The Welsh Government accepted in its written opening statement that the move to centralise NHS-led procurement for the social care sector could have been put in place earlier in March 2020. That move may have quickened the improved availability of supplies for the sector in the very early days of the pandemic. That said, the care sector distribution difficulties experienced early in the pandemic were exacerbated by the fragmented nature of local government procurement in Wales. Mr. Brace and other witnesses highlighted the benefits of having, in the NHS Wales Shared Services Partnership, an expert central NHS procurement function with experienced personnel and well-established processes, which was able to ramp up its usual activities without the need suddenly to develop new structures. Coming into the pandemic, local authorities in Wales had no such centralised procurement function. Mr. Brace's evidence illustrated the practical impact of that absence. He told the inquiry that although getting a clear picture of stocks held and usage rates within local health boards was a challenge in the early part of the pandemic, there was nevertheless a lot more data, intelligence and insight with respect to those matters within the NHS because of its centralised procurement structures. By contrast, in the care sector, those structures and that data had to be generated from scratch and at pace. Inevitably, that fact was a significant factor in the local supply problems experienced by the care sector during the very early months of the pandemic. The Welsh Government will therefore discuss with the Welsh Government, the Welsh Government therefore will discuss with the Welsh Local Government Association the proposition that they take action on behalf of the 22 Welsh local authorities to develop a more collaborative approach to the management of procurement and the collection, sharing and use of data, which provides a more resilient, responsive and flexible structure in times of rapidly increased demand. Given the important evidence that you have heard during this module, my lady, we hope that the inquiry would endorse such an approach. The inquiry also heard from Andrew Slade, whose Welsh Government responsibilities during the pandemic included the Commercial and Procurement Directorate. His evidence highlighted a number of positive lessons which he recommended be reflected in a future pandemic. These included the effective use of mutual aid arrangements, the expanded role played by the Welsh Government's Commercial and Procurement Directorate, and the provision of procurement guidance and advice, and the mechanisms developed for quickly standing up the domestic production of key supplies. However, he accepted that more should have been done formally to measure the effectiveness of the efforts to stimulate the domestic production of PPE during the pandemic. Mr. Slade also indicated that the wider public sector would benefit from more experts in procurement, supply chain management and contract management, including during an emergency. Finally, questions were put to witnesses from all 4 nations, highlighting the importance of providing appropriately fitting PPE and other equipment for all those who use them, including Black, Asian and minority ethnic health and care workers. This is a lesson that the Welsh Government recognises must be learned from the pandemic. Suitable PPE and other relevant supplies must be made available for the diverse range of users, both in terms of stockpile preparations and in the course of ongoing procurement. My lady, although the hearings for this module now draw to a close, the Welsh Government will continue to consider the evidence from all 4 nations to see how best to enhance procurement practice and procedure in Wales. Thank you.
Thank you very much, Mr. Byrne. Apologies again if I caught you by surprise. I think you may have forgotten that Ms. Murnham went before lunch. Right, it's Mr. Holland now, I think. Not caught you by surprise.
My lady, I make these submissions on behalf of the NHS Wales Shared Services Partnership, or NWSSP. NWSSP is firmly part of the NHS in Wales. It is not a Welsh Government body on an arm's length basis or otherwise. Throughout the pandemic, however, NWSSP had a good working relationship with Welsh Government, which provided reliable and substantial funding to allow it to discharge the increased role which it was called upon to perform. A key component of NWSSP's ability to respond to the pandemic was this good working relationship with Welsh Government, together with the timeliness of responses from Welsh Government colleagues over resources requests, contract approvals, and information sharing. When the pandemic began, NWSSP was well established and integrated into the NHS in Wales. It does not stand as a separate board, but is hosted by Velindre NHS Trust. The Shared Services Committee, through which it discharges its functions, is required by regulation to have on its membership a representative of each health board, trust and special health authority in Wales. As its name indicates, it is intended to achieve its purposes through partnership working with those bodies. It has a Directorate of Procurement Services containing a group of dedicated and experienced procurement professionals working for the benefit of the NHS in Wales as a whole. It was clear from the evidence of Alan Brace on behalf of Welsh Government that he valued that experience. There were obvious advantages in the fast-moving sellers market in the spring of 2020 of NWSSP being able to enter into contracts on behalf of Wales as a whole. It assisted beyond the borders of Wales by contracting for a huge quantity of Type 2R fluid-resistant masks on behalf of the entire United Kingdom. The sheer volume of masks purchased under that contract allowed a very favourable price to be negotiated. In mutual aid, Wales was a net contributor. It gave out more than it received. As the pandemic began, NWSSP was responsible for business-as-usual procurement in the secondary healthcare sector, but not for pandemic or emergency procurement. It was, however, sufficiently resilient and flexible to be able to take on, at short notice, not only pandemic procurement, but also to expand its operations to the social care and primary care sectors. As you have heard, procurement among the 22 local authorities in Wales was, in contrast to healthcare, not centralised, and procurement expertise accordingly more thinly spread. Nevertheless, Alan Brace was confident that by the summer of 2020, all those in the social care sector that required it was being sufficiently supplied with PPE by NWSSP. While a formal service level agreement was not entered into until September 2020, the arrangements which that SLA reflected had been in place for some time. All offers to supply PPE in Wales during the pandemic were considered and assessed in the same way. There was no high priority lane. There was a list of critical items for which there was a pressing need and which therefore needed to be prioritised, but this should not be confused with preferential treatment of any supplier. The substantial volume of offers received was managed with the assistance of colleagues in the Life Sciences Hub. It was independently verified by the Auditor General for Wales that there was no evidence of preferential treatment in the award of contracts for the supply of PPE, and in the case of all the contracts under review, there was a proper audit trail evidencing the decisions which had been reached. The Audit Wales report found that there had been delays in the issue of contract award notices. NWSSP accepts the importance of transparency in the award of contracts and regrets these delays, which were not deliberate but due to oversight at a time of extreme pressure of work. But the Auditor General found no evidence of any substantive failures in the way in which any contract had been awarded. NWSSP accepts that there were genuine concerns in Wales, as there were throughout the United Kingdom, expressed by end users about the adequacy and sufficiency of PPE. While it has been confirmed by several witnesses that at no stage did Wales run out of PPE at a national level, that of course does not itself meet the concerns of frontline workers who had difficulty in obtaining it. The nature of the PPE to be supplied was specified by the IPC cell at UK level and disseminated in Wales by Welsh Government. NWSSP's role was to ensure that the PPE which it procured and supplied was up to standard and compliant with all regulatory requirements. This procurement services did, successfully, with the assistance of their colleagues in the Surgical Materials Testing Laboratory. NWSSP's responsibility as a distributor was to deliver PPE to each hospital's central receipt and distribution point, or in social care, to each local authority's joint equipment store. It did not have responsibility for internal distribution within a hospital, nor for deliveries to individual care homes. In April 2020, Welsh Government asked the military to review the overall robustness of the supply chain nationally. Its report concluded that while national storage and distribution was fit for purpose, there was a lack of clarity as to what stock was available in forward locations, i.e. at the joint equipment stores and within health boards. NWSSP was not responsible for the procurement of stock held in the PIP stockpile, but for its storage and distribution. On instruction from Welsh Government, NWSSP distributed PPE from the stockpile, as you have heard, on a push basis, having regard to normal levels of demand, and in the case of local authorities, the size and population of the local area. Ongoing and accurate assessment of levels of demand proved challenging, and NWSSP enlisted the support of the military and benefited from the input of Deloitte under an arrangement initiated and funded by Welsh Government. NWSSP acknowledges the importance of having PPE which fits a diverse health and social care workforce. There were, however, practical difficulties in achieving diversity of supply. Wales, in particular, was heavily reliant throughout on the international market and had limited, if any, influence on the particular specification of the product. In the case of FFP3 masks, the supply of any new or alternative products would require each user to undergo further testing for fit, putting additional pressure on health board resources which were already stretched. Arrangements and systems for the procurement, storage and distribution of PPE in each of the devolved administrations were similar, and all held up well under the increased pressures of the pandemic. In each case, on the evidence, there was a body with central responsibility for the procurement of PPE, staffed by experienced procurement professionals, with responsibility in normal times for the procurement of the great majority of the needs of the secondary healthcare sector. The contrast was between the devolved administrations on the one hand and on the other England, where in normal times the system was much more fragmented, with individual trusts being responsible for a much greater proportion of their own procurement and NHS supply chain correspondingly less. The systems in the devolved administrations were able to scale up to the challenge of the COVID pandemic without significant alteration, in a way in which the corresponding systems in England were not. It is acknowledged that one of the reasons for this was the relatively small size of the devolved administrations. This allowed for greater agility in responding to the challenges of the pandemic. It was described in Mr. Brace's evidence as small country governance, and Wales certainly benefited from it. NWSSP and Welsh Government had to respond at short notice to the failure of the UK-wide arrangements for the procurement of PPE in a pandemic by taking on responsibility for the procurement of their own PPE. Following that experience, NWSSP understands that Welsh Government expects it to continue to source, store and distribute PPE on behalf of Wales, rather than reverting to reliance on a central UK supply. Welsh Government and NWSSP are actively working on the forward plan for this provision to continue. NWSSP would wish to conclude by putting on record its gratitude for the hard work and commitment demonstrated by its own staff and those of its partners, and remembering the suffering and bereavement endured by so many during the pandemic. Thank you, my Lord.
Sorry, could you not hear me? Mr. Mitchell, sorry, maybe you couldn't hear, sorry.
I think you were perhaps muted there, my lady.
Again.
My lady, this is the closing statement on behalf of the Scottish Government. I appear today on behalf, along with Junior Counsel Amelia Ma, and we are instructed by Caroline Beattie and Callum McHugh of the Scottish Government Legal Directorate. In our opening statement, we highlighted the keystones of the approach to procurement adopted by the Scottish Government during the pandemic. We identified those as collaboration, relationships, innovation, and governance. We said that by pursuing these principles, remarkable outcomes were achieved. Now, as this module closes, we submit that these central tenets were reflected in the evidence. The Scottish Government does acknowledge that at times, particularly in the early days of the pandemic, the system was put under great strain. A sharper understanding now exists of many issues. For example, as Ms. Freeman described in such vivid terms, the importance from the outset of wrapping our arms around all of health and social care. Undoubtedly, there are lessons to be learned. In Scotland, the implementation of many of these lessons has already begun. In this closing statement, therefore, we remind the inquiry of the achievements of the Scottish Government and its partners, and we identify some areas that the evidence has shown to be habile to change. We begin with a brief resume of the achievements in Scotland. As we have seen in the evidence led, the combined skills of the Scottish Government and NSS were critical. Gordon Beattie of NSS praised the collaborative working of the single point of contact strategic PPE group. This group brought together NSS, health boards, Scottish Government, Scottish Enterprise and others, and in his view was a really useful mechanism. Mr. Coquette noted that the creation of the PPE Directorate allowed NSS to get on with what they were skilled and expert at in delivering. Ms. Freeman explained that the level of expertise within SSS and its long-standing relationships with suppliers and clinical advisors gave Scotland a significant advantage. The Scottish Government worked effectively with a number of public sector bodies, as well as with Scottish manufacturers, to produce PPE. By April of 2021, 88% of PPE by value, excluding gloves, was manufactured in Scotland. The PPE Action Plan aimed to ensure that the right PPE of the right quality gets to the people who need it at the right time. In March 2020, the Scottish Government temporarily expanded the remit of NSS to provide PPE to primary care providers and social care settings at a time when they were unable to source increased amounts of PPE from their regular private suppliers. This was done for social care primarily via a series of localised hubs, with the aim thereafter of local distribution. In April 2020, a PPE supply helpline was established by Ms Freeman for health and social care staff who needed PPE and to which clinical advice entitled them. As Ms Freeman put it in evidence, she wanted a means by which staff on the front line could raise directly with the Scottish Government issues that they were experiencing whilst on shift. While she and Mr Coquette accepted that response times were initially too slow, within a month those response times had improved considerably. In accordance with principles of good governance, offers of help received by the Scottish Government were triaged. To be clear, this was a triage of offers, not simply a triage of people. As we said in our opening statement, no concerns of fraudulent conduct arose in relation to procurement or award of contracts. No conflicts of interest by civil servants or ministers were identified. I turn now to other issues that were raised in evidence and looking firstly at data. The Scottish Government recognises the importance of comprehensive and reliable data. As Ms Freeman said, the Scottish Government accepted that the quality of data needed to be improved. An inventory management system was discussed early in the pandemic when it became apparent that there was not clear visibility of the level of PPE stock within health boards or across Scotland. In March of 2023, such a system was rolled out across all health boards. The system provides boards with current data on consumable stock levels and will, in due course, provide data on costing and clinical variation. All this will ensure less waste. In relation to ICU equipment, Ms Lamb noted that there was not systematic visibility on the precise locations and types of equipment being used. However, by September of 2025, a national medical equipment management system will be operational. This will provide national oversight of NHS Scotland's medical equipment inventory, thereby improving patient safety and outcomes. Turning now to diversification of supply chains. The pandemic demonstrated that just-in-time contracts for PPE were not effective in an emergency situation. They are not currently being considered in Scotland for use in pandemic planning. As the evidence has shown, during the pandemic, the Scottish Government worked very successfully with Scottish Enterprise, NSS and Scottish Manufacturing to develop new supply chains and sources of PPE and equipment. As Mr Beattie described it, this transformed what we were doing. The urgent need of the country was met and greater self-sufficiency was created. Since the pandemic, NSS have diversified their supply chains and reduced reliance where possible on single production centres. Under the Scottish Government Future Pandemic Preparedness Programme, a PPE delivery group has been established to provide continuing assurance to ministers that appropriate planning for the provision and distribution of PPE is in place across key sectors. Further, all NHS boards now hold ICU equipment to support double ICU capacity. Looking now at the stockpile, it is important to note that while in April 2020 stocks of PPE were low, these were stocks that were held centrally. In other words, PPE was being sent out to health boards as quickly as could be managed. As Ms Freeman confirmed, at no point did Scotland run out of PPE. That said, Ms Lamb recognised that the available stockpile was not big enough to deal with a pandemic of this nature. To that end, Scotland now has an increased stockpile holding based on a 12-week peak demand level and plans for rotation of NSS PPE stocks using business as usual use and surge capacity. Ms Lamb said that change implemented a key lesson learned. Looking now at funding issues. In our opening statement, we mentioned the lack of a mechanism to request emergency or additional funding. over and above that generated by Barnett. This issue arose following the need early in the pandemic for the Scottish Government to procure PPE and supplies, in addition to the limited amounts supplied by the UK Government. Scotland wasn't getting what it needed from the UK Government, and so had no choice but to procure its own supplies to protect its frontline workers. As Ms Lamb explained, the balance of risk favoured ensuring that Scotland had the supplies to provide appropriate and adequate PPE to the NHS and beyond. As the inquiry has heard, the issue of funding was raised in a joint letter from the devolved administration finance ministers of 12 May 2020. Although there was constructive and collaborative working between governments to try to resolve this issue, the Scottish Government had to bear an otherwise unacceptable financial risk while a funding solution was being considered. In a future emergency situation, a formal mechanism for emergency funding would provide considerably more resilience and allow for a more flexible and proactive approach. Now turning finally to expert evidence and Four Nations procurement. Professor Manners-Bell gave evidence as to the desirability of having a control tower overview of the complete UK inventory of PPE and equipment. His evidence also covered the establishment of a structure to allow formal communication between the UK Government and the DAs on PPE. This structure would meet regularly in business as usual times to monitor the market and to plan for emergencies. The Scottish Government certainly recognises the benefit of a shared awareness amongst the Four Nations of supply stocks. A Four Nations procurement group was put in place to facilitate engagement on PPE guidance, stocks and supplies, demand modelling and communication. The Scottish Government engaged in this process in the spirit of mutual collaboration. It did share information with DHSC, but received little in return, at least prior to February 2021, and the establishment of the Four Nations PPE Collaborative Protocol. The Scottish Government submits that for a structure such as the one recommended by Professor Manners-Bell to be effective and efficient, it would require each of the Four Nations to attend as equal partners. There would require to be parity of esteem. Otherwise, from a Scottish Government perspective, it would not materially improve our ability to respond effectively to a future crisis. The Scottish Government adheres to its position that it is not persuaded as to the benefits of a Four Nations body tasked with procurement. We must remember that health and social care in Scotland is devolved, as too is procurement. Thus, innovations or alterations to Scotland's existing procurement system should not be allowed to complicate those arrangements. The current system draws upon NSS expertise and knowledge of Scottish requirements, and is well matched to Scotland's size, population, and the close relationship that exists between the Scottish Government and health boards. Furthermore, as Ms Freeman noted, the current system provides for the necessary democratic accountability. My lady, in conclusion, we submit that the evidence in this module, both written and oral, has shown that throughout the pandemic, the Scottish Government collaborated, innovated, and forged relationships. It has also learned valuable lessons, many of which have already been translated into positive action. The Scottish Government would once again wish to pay tribute to all its partners with whom it worked and strove to keep the people of Scotland safe through the provision of essential supplies and equipment. Before I sit down, my lady, I would like, on behalf of the Scottish Government, to extend our thanks to the inquiry for the work that has gone into this module. Those thanks, of course, go to everyone involved, to the legal teams, to the ushers, to witness support, and to RTS, and of course to you, my lady, for your continued chairing of this inquiry. Thank you.
Thank you, Mr Mitchell. Ms Doherty, I think you're next.
Thank you, my lady. Yes, I appear on behalf of NHS National Services Scotland, or NSS for short. Having had the benefit of considering the evidence presented in this module, including that of Gordon Beattie from NSS, I'd like to take this opportunity to focus on two topics arising from the evidence before making short observations and then concluding thanks. The first topic arising from the evidence that I mentioned is the effectiveness of national procurement systems, which are distinct from those of the other 3 nations in the UK. As the inquiry has heard, national procurement has its own processes and systems in relation to procurement of healthcare-related equipment and supplies in Scotland. Health has always been a devolved matter. National procurement's processes and systems are appropriate for the structures and needs of the NHS in Scotland. By the time of the pandemic, national procurement already had an established core procurement team. Many of its members had been recruited in the early 2000s, so had many years of experience working in the NHS, and therefore had established networks across the NHS in Scotland and with key suppliers. When the UK government's just-in-time strategy for the UK PIP stockpile failed due to the collapse of the international supply chain, national procurement required rapidly to take steps to procure supplies to meet the needs of frontline services, care services and unpaid carers in Scotland. It used its existing arrangements and processes for procurement with some adaptations. It did not create a high priority lane for offers of supply of PPE and other key equipment. Instead, it was mostly able to rely on established contacts with key suppliers who were contacted to establish product availability within core categories of required PPE. In addition, between 17th April and 19th June 2020, it operated an online supplier portal to receive and manage the surge in offers to supply products. The Scottish Government led on modelling to determine what supplies were needed and in what quantities, which national procurement then sought to procure. Importantly, national procurement sought to secure supply lines going forward for an indeterminate period of time, not just to buy items as a one-off, given the uncertainty as to the potential duration of the pandemic. Objectively, my lady, the evidence, including expert evidence, supports that national procurement systems during the pandemic were effective. The necessary supplies were procured and distributed. The evidence also supports that there was collaboration by Scotland with the other 3 nations in order to support mutual aid and to ensure that actions in Scotland did not have a detrimental effect on the supplies of PPE elsewhere in the UK. The second topic arising from the evidence that I want to mention is the evidence of the level of PPE in Scotland during the pandemic. As has been confirmed by Audit Scotland, at no point during the pandemic did the NHS in Scotland run out of its national stock of PPE or other key healthcare equipment or supplies. National procurement always had replacement stock coming in before its stock levels reached zero. Despite having clear oversight of national stock levels, at the start of the pandemic, national procurement did not have oversight of local department or ward levels of stock. In response to this situation, a regular stock count was introduced in hospitals, and this was followed by the introduction of a national inventory management system across the Scottish health boards, which helped to ensure that the right stock was in the right place at the right time and that it was being distributed fairly. Turning now to some observations. Given the evidence presented in this module, the following 3 matters are important to note going forward. First, the just-in-time strategy, whereby around 8 weeks' worth of UK pandemic stockpile was maintained, which was expected to allow sufficient time to buy and replace stock, simply does not work in a pandemic. Such a strategy is vulnerable to a sudden supply chain collapse, for example, when countries close their borders. Secondly, there is inevitably a cost associated with maintaining a large stockpile of PPE and or maintaining manufacturing capacity in the UK, only required in the event of a pandemic. However, such maintenance is the country's insurance policy, and like an insurance policy, if you do not pay the premium, you do not benefit from the insurance. Thirdly, collaborative work should continue across the 4 nations on an equal partner status to share best practice and to develop innovative solutions. Finally, some concluding remarks, my lady. National procurement's priority during the pandemic was to protect frontline services, staff, carers, patients and residents across health and social care. In my submission, the evidence shows that national procurement systems and processes operated effectively to do so. NSS wishes to take this opportunity to acknowledge that those working in procurement during the pandemic were working very hard over long hours for extended periods of time under enormous pressure. These individuals, like everyone else, were also suffering personally from the pandemic and its consequences. In addition, most of them worked and continue to work closely with frontline NHS staff. As a result, they fully understood what was being faced and what was needed in order to help to protect services and save lives. NSS is very grateful to them for their crucial role at such an important time. Thank you, my lady.
Thank you very much indeed, Ms Doherty. Mr Delby.
Your Ladyship will recall that the opening statement on behalf of the United Kingdom Health Security Agency, or UKHSA as I will refer to the agency, referred to 3 areas to take into account that are important for making recommendations for the future. Taking them in a slightly different order today, they are transparency, partnerships, and capable commercial systems. UKHSA's written evidence details the extensive work that has been done and is being done to take forward the lessons from the pandemic in relation to procurement. The lessons cut across modules because, as everybody in this module will appreciate, the commercial cannot be separated from the science. And in acknowledging that the two are intertwined, my lady will recognise that future commercial systems will need to be as adaptable as the science of a future pandemic requires them to be. As both your ladyship and UKHSA have acknowledged, they need to be pathogen agnostic. The practical consequence of not knowing what the characteristics of the next pathogen is, how it might be transmitted, how infectious it might prove, is that the procurement needs of the next pandemic may well be very different. And it is for that reason why, when looking to the future and in examining what equipment, tests and measures worked well for COVID-19, we all must avoid creating the risk that your ladyship identified in Module 1, that is, a failure to consider a wider range of public health scenarios. For UKHSA, the need to avoid that risk means adopting systems and processes in peacetime that would allow it to be better placed to procure diagnostics and tests that may be needed for pathogen X. During the course of this module, your ladyship has asked witnesses about practical, cost-effective recommendations, bearing in mind the difficult funding decisions that will need to be made by the government in relation to the allocation of resources. That links to a factor that UKHSA has drawn to your ladyship's attention before: risk appetites changing. By reference to those 3 themes we mentioned, UKHSA want today to make the following observations, which we will develop in our written closing statement. Firstly, on transparency. In his opening statement, counsel to the inquiry observed that the starting point is that the public has a right to know how their money was spent. And that is true regardless of whether the country is in the midst of a pandemic or not. It was explored with commercial officials whether they had treated transparency requirements as dispensable during the pandemic. That was not their evidence, but they did accept that the priority was to procure. Of course, transparency in the commercial process is vital, and the observations we make today is not intended to dilute that point. But if at the end of the process you have nothing to show for it, is that a better alternative? If the objective is for the public to know how their money is spent, shouldn't the key question be, how can we make that information more accessible to the public? Your ladyship will have heard in Module 4 the work that UKHSA has done to make information accessible around its services concerning vaccines. And in Module 7, my lady will hear about the time and energy that was put into making information about testing and tracing services more accessible to the public. But in Module 5, the accessibility of procurement information and the transparency of the commercial pipeline is, as it necessarily must be, a cross-government initiative. we drew attention to the practical benefits of the Procurement Act and so highlight, as a consequence of the Act, the Cabinet Office has unified 2 separate digital platforms into a single site which makes procurement notices and related public procurement data accessible to anyone. The information to be published on the platform is more wide-ranging than that required under the 2015 regulations. The data will be published in line with the Open Contracting Data Standard. That means data should be correctly attributed to specific parties, processes, contracting authorities, suppliers, procurements and contracts. Information associated with the procurement will be linked together, and that facilitates tracking and analysis of procurements. My lady, the importance of this step should not be ignored. It enhances public understanding and scrutiny, and so accountability. It allows for the public to themselves answer the question, how is our money being spent? And it does it so without the need for a new quango. We have already highlighted the importance of transparency in relationships between government departments and with suppliers. So we would emphasise the following points. Firstly, your ladyship heard evidence about the speed at which spending approvals had to be sought, the specifics of which UK HSA will deal with in its written closing. But looking forward, in the event of a future pandemic, UK HSA would welcome a cross-government agreement for the creation of adaptable blueprints on how to run emergency spending approvals, particularly involving large sums. Those blueprints should include clear lines of accountability. So, for example, ministers would know how and when to approach their peers for information rather than going direct to other departments, non-ministerial executives or civil servants, however senior. They should include plans for the establishment of investment or approvals boards or processes that may need to be set up again. The scope and membership of such boards should be settled in advance, including the standing expertise from the Treasury and the Cabinet Office. Second, with suppliers. Professor Sanchez-Graels appeared to advocate for an approach where, in a pandemic, the contracting authority goes out to market with their maximum price and specific technical requirements and says, whoever can meet this will get a contract. Anyone who's had to negotiate a plea or a settlement in a robing room may well raise their eyebrows at starting with your final offer. But even if that approach is the right one in a pandemic for established products, the unique challenge in tests was and continues to be, you cannot publish specifications for something that does not exist. Transparency is better met by having a clear front door, a step that UK HSA has already embarked on. And what does that offer? It provides a single point of entry to the commercial process where suppliers are aware of the categories or types of products that they may be asked to provide, and that in turn requires the development of scientific and commercial partnerships, which brings me on to the next theme. In making recommendations, my lady will have to grapple with the obvious tension in the evidence that your ladyship has heard. On the one hand, your ladyship has heard extensive questioning about the flaws of pre-existing relationships. But on the other hand, your ladyship has heard extensive evidence from commercial professionals across the public sector and, critically, from Professor Manners-Bell about the need for deep strategic relationships with suppliers to maintain supply chain resilience. Recommendations must find the middle ground, and in considering such middle ground, it is beneficial to consider the reasons why the High Court concluded the operation of the PPE high priority lane was unlawful. The flaw in that prioritisation system was not simply to do with the names of the email inboxes. The flaw was that the decisions on whether a supplier should be prioritised and so benefit from a faster process to technical evaluation included a freestanding criterion related solely to the referrer. In questioning, counsel to the inquiry relied on UKHSA's own review, which showed that the largest sums in testing were awarded to a supplier connected to the priority named testing inboxes by one email through Dominic Cummings at number 10 in July 2020. That point needs to be put in context. Exhibited documents from that review, which the inquiry will no doubt review again, show that the supplier's agent had been in touch with the testing commercial team since March 2020. They had already put a different test through validation, which failed in April 2020, and that at different points when testing products for the lateral flow devices were awarded to them, they had, 1, passed technical validation, which was not a documentary exercise, but, as explained in UKHSA's science and technical statement, an in-depth, multi-phased validation process undertaken by PHE. 2, they were the first to offer boxes of tests in 3s, 7s, and 25s, which offered flexibility. 3, they had the capacity to provide the amounts sought. And finally, as my lady will see in our written closing, that the timing of the contracts tracked the shifts in policy position and discovery of variance. Again, the unique challenges in the procurement of tests included the absence of COVID-19 tests at the outset of the pandemic. And so in that scenario, not only are you trying to acquire, you are trying to find. And to find a test that works, that can meet the objectives of speed and quality, one must test everything scientifically viable. An open approach is necessary to create a competitive market that can eventually drive towards the objectives on cost. Creating market for tests in respect of pathogen X will have some degree of scientific uncertainty again. To be better prepared for the next pandemic, it is important to know the market, maintain it, and keep it warm. As you have heard from various witnesses in this module, and indeed in Module 4, it is far more challenging to build from scratch. But from the same witnesses in this module, you have heard it is expensive to do so, standing face to face with that difficult decision on funding priorities. How has UKHSA confronted that challenge so far? My lady has already heard about the Vaccines Development Evaluation Centre in Module 4. And from Ms. Collins' evidence, the establishment of the Diagnostics Accelerator. Your ladyship also heard from Ms. Collins that UKHSA are developing a new microbiology framework and a diagnostics and research framework, updating the previous microbiology framework that had to be revisited during the pandemic. It is also developing a partnership framework for strategic relationship management. But strong relationship management needs good quality commercial professionals, leading us to the last theme, capable commercial systems. Hopefully what your ladyship has seen through the exploration of issues in this module is that the civil service commercial workforce who served through the pandemic were a group of committed and well-trained individuals who acted from the best motives, often while confronting the very human impact of the virus that they were experiencing in respect of their own loved ones. For specialist sectors, such as diagnostics, one needs a commercial workforce that understands the markets and innovations. The realised benefit in creating UKHSA has been the close, ongoing working relationship between the commercial professionals and the science and technical experts. But the challenge in the pandemic is, how do you get 50 of each of them? Or put another way, given the inevitable need to surge your workforce, can you create a reservist civil service? Even with the complex transactions team, the government's commercial consultancy service, more commercial professionals were needed to procure at scale and speed. The government commercial organisation allocated commercial professionals to the testing commercial work, but those moves were based on individual choice, leaving NHS Test and Trace reliant on external professionals. And as your ladyship heard, partway through the first year of the pandemic, other departments asked for their commercial professionals back from NHS Test and Trace. We highlighted in our oral opening that planning for a surge workforce is not a straightforward exercise. So in the meantime, and bearing in mind your ladyship's questions about practical, cost-effective recommendations for the future, UKHSA would invite consideration of this proposal: that an agreement be established by the government commercial organisation whereby, in the event of an emergency, an appropriate mandatory allocation of workforce resource will be diverted to provide additional support to the procurement of diagnostics and medical countermeasures. Such can be implemented while difficult decisions on a surge workforce are taken by the elected decision makers. My lady, that concludes the closing submission on behalf of UKHSA.
Thank you very much indeed, Mr. Delby. Mr. Stanton.
Thank you, my lady. My lady, the BMA views the procurement and distribution failings during the pandemic in two parts. First, woefully inadequate preparation, and second, a lack of timely action in the early months of 2020, compounded by a series of flawed and ill-judged decisions. Starting with preparations, the PPE stockpile was not fit for purpose. The quantities of stock were far too low, and it needed far more than just a few weeks of supply to have mitigated the inevitable supply chain disruptions. The blinkered focus on an influenza pandemic was another serious flaw, which resulted in a stockpile seriously deficient in respiratory protective equipment. A further flaw was that the stockpile had not been properly maintained. Large numbers of items had either expired or the expiry date was unknown. In Wales, for example, a shocking 90% of FFP3 respirators in the stockpile were out of date. Health and social care staff across the UK were provided with PPE bearing multiple expiry date stickers, which exacerbated by a lack of communication, completely undermined trust and confidence. To have relied upon such a small, inadequate and poorly maintained stockpile based on a contingency of just-in-time overseas supply was utterly ludicrous. It was entirely predictable that supply chains would be disrupted in the event of a global pandemic, and that this disruption could last for months, not weeks. Three key mitigations would have been a larger and more diverse stockpile, the ability to stand up domestic manufacturing capability, and stronger direct links with overseas manufacturers rather than relying on contracts with distributors, which quickly collapsed. Other failings of preparedness beyond the PPE stockpile include ventilator shortages. The UK had far fewer ventilators compared to other countries, a limited understanding of the number of ventilators we had available, and no existing domestic manufacturing. In the first wave of the pandemic, staff and patients did not have access to the ventilators they needed. Localised shortages meant that anaesthesia machines, which are only designed to be used for a few hours at a time, were repurposed and substituted for ventilators. And as described by Professor Munasinger, this would have potentially impacted the quality of patient care. And Lord Agnew explained that ventilator availability played a role in whether ambulances could be sent to certain hospitals. In addition to impacting patient care, these ventilator shortages also caused additional stress, anxiety, and moral injury for staff. Another example is the lack of an inventory system that recorded PPE and equipment meant that it was not known what each NHS trust or board held, let alone other healthcare settings such as primary, community, or social care. And as a final example, a supply chain that was unfit for purpose, with warehouses designed to hold only 3 weeks' worth of stock and no plan at all to distribute items to the 58,000 primary, community and social care settings in England alone that were relying on this life-saving equipment. Moving to the lack of action in the early months of 2020, despite knowing about the threat of COVID-19 since late December 2019, it was not until early March that it was accepted that the just-in-time contracts would fail and that the NHS supply chain would not be able to cope with the demand for PPE, leading to a desperate scramble to set up an entirely new PPE procurement and distribution system while simultaneously trying to acquire and distribute PPE and respond to the avalanche of offers that resulted from the PPE call to arms. In the words of Andy Wood of the Cabinet Office, we had to build the aeroplane as we were flying it. The inquiry has heard that the additional procurement staff needed for the new system were not put in place until around the 21st of March 2020, just 2 days before the UK entered lockdown. As described by Sir Gareth Rhys-Williams, this initial lack of procurement workforce led to substantial backlogs, and a few hundred offers of PPE were left sitting unprocessed for a couple of weeks. For the healthcare staff facing a potentially deadly virus without any protection, particularly in the early months, it is painful to think what difference these unprocessed offers may have made. Similarly, no proper data management systems for managing PPE offers were set up until the 9th of April 2020, prior to which staff struggled with an Excel spreadsheet containing nearly 1.4 million pieces of data, which did not have the functionality needed for staff to be able to effectively prioritise and manage the offers they were receiving. Alongside the lack of timely action, there were a number of seriously flawed decisions, and for present purposes, we focus on just two. First, the high priority lane. It undoubtedly created the perception among both the public and healthcare workers alike that ministerial contacts were receiving preferential treatment at the expense of other potential suppliers. And it has caused significant damage to trust in public procurement processes. This concern was entirely predictable and avoidable and will, the BMA suggests, be a key area for future learning. Another consequence of this perceived bias is that it has detracted from the tremendous contribution of the many civil servants who were working 16 to 18-hour days to procure PPE for frontline healthcare workers. The second area of flawed decision-making is the restrictions on the use of respiratory protective equipment because of a lack of supply rather than for reasons of safety. This is described within the DHSC's own PPE supply and demand report as a measure to, quote, reduce demand with policy, close quote. Within disclosed email correspondence and meeting minutes, there is clear evidence that senior decision makers knew in January and February 2020 that the stockpile was lacking in FFP3 respirators, that there would be a worldwide shortage with no means of procuring sufficient numbers for many months, and that fluid-resistant surgical masks would not protect healthcare workers against an airborne virus. For example, emails sent during this period by Professor Jonathan Van Tam and Dr. Lisa Ritchie demonstrate awareness that, in the context of FFP3 shortages, staff access to this vital equipment would need to be managed. What should have happened at this point was for senior decision makers to have had the courage to candidly explain to healthcare workers that the country simply did not have sufficient quantities of this equipment, that equipment would be rationed to the highest risk settings and procedures, and that everything possible was being done to procure adequate supplies. As Mr. Mortimer of the NHS Confederation told the inquiry last week, healthcare workers, quote, appreciate the truth and would have been and would still be much more accepting of a truthful approach, close quote. A view that was also strongly expressed by Dr. Barry Jones of CATA in his Module 3 evidence. Instead, healthcare workers were subjected to the following irrational decisions. First, FFP3 ordering restrictions placed on NHS trusts in February 2020, which inexplicably limited orders to the preceding 12 months business as usual demand, despite being on the cusp of a global pandemic. Second, PPE demand modelling based on, quote, real usage of PPE. This was illogical given the known acute shortages of PPE and, as the oral evidence of Rosemary Gallagher identified, the fact that staff were very sparing in their use of PPE because they did not want to run down stocks for colleagues, all of which meant that real usage was not an appropriate measure against which to procure. And third, changes to the IPC guidance produced by the four-nation IPC cell on the 13th of March 2020 at the height of concerns about FFP3 shortages, which limited their use to ICU settings and aerosol-generating procedures only. This was 6 days before NERVTAG declassified COVID-19 as a high-consequence infectious disease on the 19th of March 2020, and it meant that a healthcare worker providing close care contact to a COVID-19 patient was only provided with a flimsy surgical mask rather than an FFP3 respirator. This was in no way a decision that protected staff and patients, but was the rationing and demand management of essential safety equipment because of shortages, as set out in the DHSC's PPE supply and demand report at INQ 000 339 131. The failure to honestly and openly explain the nature of the problem had two profound consequences. First, those responsible for procurement did so based on false and suppressed demand, which incredibly led to a stop order of further FFP3 on the 30th of June 2020, whereas all that had been procured at this stage was sufficient FFP3 supply for ICU settings, not more general settings. Second, healthcare workers knew that they were being let down, that they were not being properly protected, and that decision makers were not being open and honest with them. This has caused a serious breach of trust and confidence, which is ongoing and will not be resolved until there is an acknowledgement of the truth and a change to the IPC guidance, which to this day continues inappropriately to only recommend surgical masks for staff treating COVID-19, not the FFP3 needed to protect against an airborne virus. Turning to impacts on staff and patients, healthcare workers described living in constant fear for their own lives and the lives of their patients, colleagues, and loved ones. As one doctor told the BMA, I felt that my personal health and my life and the health of my family didn't matter to anyone. Access to PPE varied widely between healthcare settings, and the focus on secondary care meant that primary, community, and social care faced particular challenges in keeping their staff and patients safe, especially in the early stages of the pandemic. As a result of a lack of protection, large numbers of staff and patients were infected with COVID-19. Significant numbers developed long COVID and continue to experience the effects on their personal and professional lives. A consultant told the BMA that, quote, I contracted COVID-19 in my workplace due to lack of appropriate PPE. As a result, I have suffered long COVID and following relapse have not been able to work for 5 months. This has been devastating to lose my ability to work in a job that I love. Close quote. Similarly, in Module 3, the inquiry heard from Nicola Ritchie, a physiotherapist who requested to use FFP3 while providing COVID care but was denied this protection based on the IPC guidance. Ms. Ritchie developed long COVID, continues to experience poor health, and is unable to resume her career. Tragically, many staff who did not have access to PPE or the right PPE died, and there have also been a significant number of deaths from nosocomial infections. In respect of equalities issues, female and ethnic minority staff experienced disproportionate difficulties in accessing well-fitting respiratory protection. Some witnesses have suggested that this problem was not known prior to the pandemic. However, guidance from the Health and Safety Executive, published in 2013, highlighted that one size of respiratory protection will not fit all shapes and sizes, and that differences will be more significant along lines of gender and ethnicity. It is important to stress that this is not simply a preference for a specific mask. Rather, a properly fitting respirator saves lives and is fundamental to safety. The inquiry's Module 1 report concluded that pandemic planning did not properly consider inequalities and had too narrow a view of vulnerability. The lack of diverse PPE procurement is a glaring example of this failure. My lady, the BMA highlights the following recommendations. First and fundamentally, the UK's pandemic preparedness needs to take a precautionary approach to the use of PPE and other equipment. And this includes having a much larger stockpile of PPE with a wider range of items suitable for a broad range of pathogens. It needs to be properly maintained, its contents need to reflect the diversity of the workforce, and there needs to be a plan to swiftly distribute key equipment to all health and care settings. Second, there needs to be a fundamental change to the UK's reliance on just-in-time contracts. This includes stronger links with manufacturers in a diverse range of countries, as well as domestic manufacturing capability. Third, there needs to be improvement in the information available to decision makers during a crisis, most obviously with inventory management systems. Fourth, product specifications and procurement processes need to incorporate frontline clinical and end-user input from the outset. Fifth, steps must be taken to ensure that in a future pandemic, healthcare staff have access to the vital equipment they need to protect lives. This includes ensuring reliable oxygen supplies through upgrades to hospital estates, as well as ensuring sufficient ventilator supply alongside the beds and staff capacity needed to support their use in a pandemic. And sixth and finally, to reinforce the need for transparency and honesty. Trust has been severely damaged by failings in PPE provision, by the IPC guidance being used as a tool to ration access to PPE, and by perceptions of preferential treatment through the high priority lane. And there is an urgent need to restore it. My lady, that is the closing statements of the BMA. This is the last module in which the BMA is a core participant, and it is grateful to have been given the opportunity to participate. Thank you.
Sorry, again, didn't unmute myself. And I've been grateful to the BMA for all the help that they've been giving. Thank you, Mr. Stanton. And I think last but not least, Mr. Heyman.
My lady, thank you so much for allowing the UK Anti-Corruption Coalition to make this closing statement. We wanted to reflect on some of the key things we have learned over the last few weeks of hearings. Before I share those, I would like to refer to the moving statement from Professor Fung, a doctor at University College NHS Trust in London, in the earlier modular inquiry. He said, "Things got so bad, they were so short of resources, they ran out of body bags, and they were instead issued with 9-foot clear plastic sacks and cable ties." And nurses talk about being really traumatized by that because they had recurring nightmares of feeling like they were just throwing bodies away. This is a graphic example of the human impact of procurement failures during the pandemic. It seems neither the living nor the dead were fully protected from the past government's poor emergency procurement practices. Now, as UK ACC, we have provided the inquiry with detailed, data-driven analysis of our key concerns over that poor purchasing and how it wasted huge amounts of public money, how it distracted attention from more credible suppliers, and even more importantly, how it risked lives by purchasing defective items. Former Secretary of State Matt Hancock dismissed many of the Council's questions in this module about his procurement decisions, saying they were naive because you had to be there. Well, we were there. My organisation, the Open Contracting Partnership, was directly involved in helping other countries with their pandemic procurement. And there were so many better emergency procurement strategies the UK should have used, but didn't. Something Professor Sanchez-Grales also points out in his expert report to the inquiry. Listening to witnesses during the module, I didn't hear anyone say there was considered emergency procurement strategy at all. As Lord Agnew reflected, we were rabbits in the headlights, and that he was a platoon commander defending Dunkirk, but it was a military disaster. We heard how the unfocused, even amateurish call to arms by politicians overwhelmed the system and sourcing of PPE. Rather than setting out clear specifications based on this is what we need, with an orderly, structured qualification process, as someone said, a clear front door, and setting out open frameworks for PPE procurement, which companies could then present their credentials and get kind of certified as a supplier, as many other countries did, the UK took a what have you got approach based around prioritising political referrals. Who you knew mattered much more than what you knew and what supplies you had. And as we heard, you were over 10 times more likely to get a deal if you made the VIP lane. Dawn Mathias-Jackson, a PPE caseworker seconded from the Department of Education, said in an email disclosed to the inquiry, "Some days I feel like I'm in a loony bin. I was promoted yesterday to the VIP supplier team, basically allocated to dealing with suppliers who feel it's important for them to contact Boris, Matt Hancock, Gove, Gareth and other ministers directly. So now I'm basically jumping through hoops to get quick responses to them before they complain we are not taking it seriously." Only one so far has proved of any use. We heard some senior ex-politicians double down their evidence and they were somehow inevitably going to come across the best offers. But really, no evidence of that has actually been shown during the hearings. Indeed, as UKACC, we shared evidence with the inquiry that VIP lane deals actually had a higher failure rate than other sources. You can't have it both ways. If you care about PPE and saving lives, you need a professional, structured process that delivers results, not hugely risky contracts with untested suppliers. Was it really the best we could do toward mission-critical PPE contracts worth over £1 billion in total to companies specialising in lingerie, drinking straws, beauty and fashion accessories, confectionery, investment management and HR consulting? We also heard that VIP-led suppliers were, on average, paid 80% more per unit than other suppliers, and some contracts were agreed at more than 4 times the average price. We will help you find less reliable companies who will charge you a lot more money is hardly an effective mechanism for prioritising PPE sources and saving lives during a pandemic. And this approach of large, risky, direct awards went on way past the initial stage of the pandemic. As Lord Agnew acknowledged in his testimony, there were too many direct awards and that we took too long to pivot to competitive tenders once the initial panic subsided. Lord Agnew told us about the runaway ordering and lack of any inventory management by the Department of Health especially. He said it was over-ordering by an order of magnitude because we didn't have the data, and that we had not got a clue what we had when we were ordering more. I note Matt Hancock dismissed our data as UK ACC in this regard, that showed how the UK used more direct awards for larger amounts of money for longer than its European peers. He said our charts were meaningless because the UK had a different medical system from other European countries. But he is wrong. The data is comparative and the charts are meaningful. We've shared a detailed rebuttal with the inquiry of his assertions. But NHS or not, tenders in the categories of medical equipment relevant to PPE are published across Europe relatively consistently. In 2019, the UK was about 15% of European GDP, and indeed, it accounted about 14% of the total value of published tenders across Europe in those PPE categories we shared our analysis with you on. Then in 2020, such was the scale of its buying, the UK shoots up to be over 65% of the total awards in those categories across Europe, worth about, the UK spending about 28 billion euros in regards to those categories. Let me also set the record straight on one other thing Matt Hancock said under oath. He said the government got into trouble in what he describes as a ludicrous court case because a few contract award notices were late by a couple of weeks. I assume he's referring to the case the Good Law Project and 3 opposition MPs won in the High Court. To my mind, the case was far from ludicrous because it involved publishing timely contract award information at a time when information on who had stocks of COVID PPE is absolutely vital to help buyers and suppliers connect in a disrupted marketplace. If your objective is to save lives, you should be prioritising publishing that information to help buyers and suppliers connect, not delaying it or treating it as an inconsequential afterthought. Other countries openly shared buyers' lists of qualified suppliers, whereas it appeared the UK hindered that response and didn't share vital information. Our own analysis of the UK government's published procurement data shows the average PPE contract award notice was published over 100 days later, I repeat, 100 days later, than all other contract award notices at the time. It takes about 10 minutes to publish these notices, and we said how useful they are for buyers and suppliers connecting. So why were they published so much later than everything else, especially if the priority was to save lives? We're still not sure we got to the bottom of all those VIP contracts themselves. It appears that the evidence for the inquiry on VIP lane suppliers from the Department of Health conflicts with that of Claire Gibbs and Gareth Reith-Williams of the Cabinet Office. The Cabinet Office evidence appears to omit 20 other suppliers who received 48 contracts worth about £1 billion in total that are recorded in the Department of Health evidence. I'm not sure who is right and who is wrong, but it's bad we still don't know for sure 5 years later. Hopefully, my lady, you will get to the bottom of it. Finally, we heard about the outdated technology being used to coordinate procurement. Excel spreadsheets, SurveyMonkey, and a basic email address, as opposed to digital tools available to other governments, such as e-procurement systems, structured digital workflows for contracting and for qualifying offers, and real-time data dashboards. If, say, Colombia, Ecuador, Lithuania, Moldova, and Ukraine can build public data dashboards, why couldn't the UK? These primitive tools compounded the challenge of triaging 25,000 offers from 15,000 companies that gave birth to the VIP lane. The good news is that with the new Procurement Act and its open contracting data standard provisions, we would be in a much better situation to do this in future, assuming government departments publish their contracts accurately and on time. Let me close our recommendations to the inquiry. First, there should be a comprehensive emergency procurement strategy for a UK-wide disaster drawn up, including planning for cross-government coordination, how to surge staffing, centralised purchasing, and with clear leadership and accountability. Other countries draw up proactive framework agreements to scale domestic production and deliver critical items in advance of emergency, like, say, Chile does for earthquakes. Maybe that's something the UK should also consider. Second, you should make a strong recommendation for the adoption of modern digital e-procurement tools and workflows across UK procurement, supported by data, AI, and digitisation, especially the Department of Health and for any organisation that would be responsible for coordinating emergency procurement. My organisation has seen the value of such tools in our work supporting Ukraine's reconstruction, and I think it would be transformational for UK procurement and emergency responses too. Third, the inquiry should conduct a comprehensive review of the scale and outcomes from the VIP lane. It's essential to investigate whether prioritisation granted by the lane distracted attention from more established PPE suppliers who are working through standard channels, and it's also essential to establish why VIP contracts had a higher failure rate and higher prices than other routes. Based on that analysis, we suspect the inquiry would want to make strong recommendations against any future VIP lane in government and support new guidance on the roles of ministers and political referrals in public procurement, both in normal times and during an emergency. And I would add, simply declaring a conflict of interest is not enough to mitigate it, as some senior politicians seem to suggest to the inquiry. Next, I think the inquiry should examine the decision-making process and apparent lack of coordination in inventory management centred around the Department of Health that led to the massive PPE overordering and resultant issues with storage, waste and disposal on a huge scale. And lastly, the inquiry should recommend full and proper resourcing of the COVID Anti-Fraud Commissioner's Office to get back some of the huge amounts of wasted money. It's not a 3 days a week short-term contract job, in our opinion. Again, we thank you very much for allowing us to contribute. We look forward to your findings, restoring public confidence in government procurement, especially in times of crisis. The memory of those who suffered during the pandemic and the bereaved families demand nothing less than a comprehensive and truthful accounting of these events and for recommendations of this inquiry to be swiftly adopted by the government. Thank you very much, my lady.
Thank you very much indeed, Ms. Taylor. I'm very grateful. That, I think, completes the evidence and the closing submissions for this module. Mr. Wall, I think I'm right?
I think that's right.
Thank you. Just to confirm, I know everybody present understands this, but I shall obviously be considering the written closing submissions very carefully with the assistance of you and the rest of the team. It's not just the oral submissions in case people misunderstand the position. So thank you all very much indeed. Work will now begin in earnest on the report for M5. I hope it will be published next summer. If we can do it sooner, we shall. But this year is an extremely busy year. We've 4 more sets of hearings, plus the preparation of reports for all the sets of hearings that are finished. So that means work going on reports for M2, 2A, 2B, 2C, and report for M3, and report for M4, and of course now report for M5. I'm extremely grateful to everyone who's helped us complete this module on time. It hasn't been easy, I know that. Most modules have problems, but I think this module has had more problems than most. And without the assistance of everybody, the material providers, the witnesses, the core participants, their representatives, and of course, my wonderful inquiry team, it wouldn't have been possible. I know that I set what I'm told is called a demanding or challenging timetable. Some could argue it might be more accurately described as a punishing timetable. But may I repeat why we have that timetable? I'm sorry if I've said it before, but it has to be said. We must complete this inquiry before some memories fade, if we are to achieve our mutual aim of learning lessons, saving lives, and reducing the huge cost to society, the economy, and future generations of the COVID-19 pandemic. So thank you all very much. The next evidential hearing will be on the 12th of May. Goodbye.